This video is on hyponatremia. Hyponatremia gets quite a bad reputation for being a really tricky subject and hard to remember, but hopefully at the end of this video you'll have a better understanding and it'll be easier to remember when it comes to exams or when you see patients on the ward with hyponatremia, because it is quite common and bosses love talking about it. So the first thing to get your head around is that it's not necessarily changes in sodium or changes in sodium concentration which cause hyponatremia. It's more about movement of fluid, and how extracellular fluid changes is reflective in the sodium concentration. So clinical presentation: early signs may be forgetful, headaches, dizzy, gait disturbances, or weak. More severe signs, if the sodium drops below 120, for example, could be confusion, stupor, coma, seizure, or, for example, the diaphragm becomes weak. The patient may have respiratory failure. Now we're going to do this a little bit differently. Normally, if you've seen our videos before, we talk about causes pretty early on. But for hyponatremia, I think it's better if we first look at investigations and then think about how those results will create a framework for considering our differentials. It's also a bit more realistic because on the ward, you may see those symptoms. It may be a purely lab diagnosis, and then you do the whole sodium investigations before you think about your differentials. So the first thing you do is sodium osmolality, so basically concentration in the blood. Those are the normal values. Most of the time it will be hypotonic. The next thing to consider is fluid status, and this is really important because remember, we're thinking about hyponatremia in terms of fluid changes, not necessarily sodium movement. So the first thing to think about fluid status is weight. So does the patient have a baseline weight from previous records? And if so, have they put on weight? Could they be fluid overloaded or hypervolemic? Or have they lost weight? Are they hypovolemic? If you don't have weight, look for signs of dehydration, so reduced skin turgor, sunken eyes, tachycardia, or fluid overload, for example, peripheral edema, raised JVP, or pulmonary edema with bivasal Krebs. And this will tell you if they're hypovolemic with these causes, euvolemic with these causes, or hypervolemic with these causes. We're going to go through these causes more later in the video once we finish our investigations, but this shows you the color coordination and how to think about it. So the next thing is urine sodium. So test the sodium in the urine. It's mostly applicable for hypovolemic, but can be used for anything. Now, if the sodium in the urine is high, that's like abnormal. That's a bad thing because your sodium in the blood's already low. So that's weird, right? And this is because the kidney is leaking. It's not filtering properly, and sodium's leaking through the filtration into the urine. So we're thinking of renal cause. If, however, the sodium is low in the urine, we're thinking an extra renal cause, which we'll go through more with the color coordination. Finally, urine osmolality. So if it's high, this could be due to syndrome of inappropriate antidiuretic hormone. Now remember, you don't want to be losing too much sodium because your sodium in the blood is already low. So if you're having high sodium in the urine, concentration-wise, this is inappropriate, and this is due to inappropriate antidiuretic hormone. Antidiuretic hormone basically controls the volume of your urine. So if it's high, you're producing less volume for the same sodium. However, if urine osmolality is low, this is what you would expect. You don't want to be losing too much sodium per volume in the urine because your sodium in the blood is already low. So this could be due to normal water excretion, or it could be due to all the other causes we're going to talk about. Now, that really forms the basis for our causes or the investigation results. I hope that made sense. So if they're hypovolemic, so if they've lost weight or signs of dehydration, we're thinking these causes. If the sodium in the urine is high, we're thinking renal causes. So renal failure, so the diuresis part, or diuretics, or mineralocorticoid deficiency, such as in Addison's disease, where basically there's not enough aldosterone and the patient will also be hypotensive. If, however, the urine sodium is low, we're thinking extrarenal causes. And because they're hypovolemic, you have to think about, well, how else can someone lose fluid if it's not basically pissing? Well, they can lose fluid if they're throwing up, they can lose fluid in the stools, the diarrhea, or they can lose fluid with burns. Or their fluid may not necessarily be lost, it could be hiding. So it could be in the interstitium, such as in third spacing, which is associated with a variety of causes, but maybe on the ward the most common is bowel obstruction. However, the patient could be euvolemic, so their weight could be normal and no signs of dehydration and overload. If the sodium in the urine is high, remember we're thinking renal, so this is SIADH, confirmed by the urine osmolality being high. And this is in the case of malignancy or malnourishment, so maybe they're in hospital, they're not eating enough because they hate hospital food and they end up hyponatremic. Or medication related, so selective serotonin reuptake inhibitors if they have depression, or antipsychotics. However, if the urine sodium is low, we're thinking extrarenal. So maybe they're drinking too much, or they're just not taking in enough sodium, so reduce salt intake so the sodium's low. Finally, if the patient is overloaded or if they're put on weight, we're thinking hypervolemic causes. They have too much fluid and that dilutes the sodium. This could be due to renal failures, such as in oliguria, so not producing urine, or extrarenal causes such as congestive heart failure, cirrhosis, or severe proteinemia. And this, in case of cirrhosis and severe proteinemia, is related to hypoalbuminemia, where there's not enough albumin to hold the fluid, so it stays in the blood and then causing hyponatremia. Finally, with management, if they're hypovolemic, you want to make them euvolemic, so give them fluids. 0.9% saline is good, it's reasonably physiological. However, if they're euvolemic or hypervolemic, obviously you don't want to give them more fluid because you're just going to worsen the hypervolemia or make someone euvolemic hypervolemic, in which case you restrict the fluid and salt, which may make not complete sense. Why are you restricting salt if the sodium's low? But remember, it's not really a sodium issue, it's a fluid issue, so we want to restrict the fluid they're taking in. Finally, in severe cases, so if they have the severe symptoms of seizures, rest failure, they need to go to ICU and have a hypertonic saline solution because you don't really have time for the fluid or salt restrictions to kick in. Thank you for watching. I hope you learned something. If you did, please tell a friend who may also find it useful.